so much for that wonderful welcome. I appreciate it. Thank you for having me here today. I'm excited to talk about optimizing postpartum care. It's something that's passionate to me. I was very fortunate to be a part of the committee of the group that for lack of a better word, try to redesign what postpartum care looks like. And I'll get to that a little bit more. But like you said, I'm going to talk about how we can and should be optimizing postpartum care. And this is not new. We've been talking about this for a couple of years now. But so are we there yet? Is it where it needs to be? I think we're going to find that out. So next slide, please. I have no conflicts to report. Thank you. Next slide. Okay, so I'd like to ground us in this presentation and discussion that we're going to have afterwards around this quote. To optimize the health of women and infants, postpartum care should become an ongoing process rather than a single encounter. I think if we remember that, if we strive to adhere to that, I think we will accomplish that. So I love this statement. So next slide, please. So this is a wonderful graphic that looks at globally how postpartum care is handled, not just on the health side, but also in the community. Many cultures across the world enshrine or revere postpartum rituals, including traditional like foods and support for the day-to-day household and for day-to-day household tasks. But I think we all know that United States, the 6-week postpartum visit exemplifies a time period that's devoid of any formal or informal maternal support. Many of the cultures here present a 30 to 40-day period of rest and recovery for the new mother, with the woman and her newborn surrounded and supported by family and community members. So you can see we have this over in some of our Asian cultures and Asian region, Middle East. Then you see what happens a little bit more in North America. So, I just kind of like to look at this across and see how varied it is across our world right now. So, like I mentioned, what are we doing here in the United States? So, next slide, please. So, in the US, believe it or not, about 25% of mothers return to weeks within 2 weeks of giving birth. That statistic kind of blows my mind in terms of 2 weeks. That is, I think, harsh to say the least. 7% of mothers return to work within 1 month of giving birth. Greater than 25% of mothers return within 2 months of giving birth. And this is where, in the United States, we have a 66% of maternal deaths occur after delivery. Some may be immediate right after delivery in the hospital, but a large portion, as we all know, happens in the traditional postpartum period. Okay, so next slide. So what's happening during this time in postpartum? And we know we have the physical, social, psychological changes. Women are recovering from childbirth, adjusting to the changing hormones, learning how to feed the child, learning how to take care of the child. There's lack of sleep, fatigue, pain, difficulties feeding, stress, urinary incontinence, mental health disorders that we have to worry about. All of this is going back, and I can't even imagine dealing with some of these items and having to go back to work. So I think there there is a big uproar. There was a big uproar about all of this. Of course there is. And so I think there was time to reset. So next slide, please. So let's reset. And so in 2018, the ACOG president, Dr. Haywood Brown, took on this reset. He created a presidential task force for redefining the postpartum visit, postpartum timeframe. So there were members from ACOG, members from the Academy of Breastfeeding Medicine, the Association of Certified Nurse Midwives, the National Association of Nurse Practitioners in Women's Health, SASCOG, SMFM, and what we all came together, worked together, was creating a new committee opinion on optimizing postpartum care. And it really reinforced the importance of the fourth trimester and to propose how to do this new paradigm of postpartum care. There was a lot of discussion about it back, I remember, in 2018. But I just, the question that I get a lot, and I ask myself, and are we there yet? Are we with what's some of the recommendations that came out of this task force? how much did we accomplish? So let's see what the recommendations were that came out of this task force. Next slide. So the recommendations were that postpartum care should become an ongoing process. And that anticipatory guidance around that ongoing process really needs to start antenatally during our prenatal visits. I think if we look at postpartum care as a transition to parenthood and well woman care, that'll help us with this ongoing process concept for our postpartum care. But like I mentioned, the prenatal discussions that the discussions that happen antenatally, prenatally, one of them should also include about future pregnancies and contraceptive options. And so I think I want to be very cautious here and highlight that this is to be a conversation around with shared decision making, not so much oh, so you have to do, what are you doing for birth control? You have to be on birth control. It is a discussion about what would you like your future reproductive life to look like? Is there anything that I can help you with? Again, really focusing on that shared decision making. Some of the other recommendations is that contact with the new mom really should be within the first 3 weeks of postpartum. And those visits, the multiple visits, not just the one, really should include physical, social, and psychological evaluations of the new mom. Next slide. Um, those mothers with chronic medical conditions should follow up not only with OB/GYN, but also their primary care doctor or their subspecialty care. So those with hypertension, any autoimmune disorders, in this ongoing postpartum transition, we want to make sure that they get plugged in appropriately with the healthcare providers that they should. Also, out of this, we recommended that anyone who has experienced a miscarriage or stillbirth really needs the appropriate follow-up as well. So that is, I'm sorry you had, it's not, I'm sorry you had a miscarriage, I'll see you next time. It is, let's bring you in, let's talk about it, let's address your physical, your psychosocial evaluation needs to happen. Make sure that you can get through this really hard time. And one of the big things that came out of this was that the change in postpartum care and what we are all suggesting really requires policy changes. And I think that is one of the hard places where we are, where I think we have still some work to go. We've made some inroads, but I think we definitely have some ways to go. So next slide, please. So how do we talk about the ongoing process of postpartum care? We have to increase engagement because, believe it or not, as many as 40% of patients do not attend their postpartum visits. And so some things that we can do is, like I mentioned, discuss this during prenatal care, not just at your 39th week visits, not just in the hospital, but let's start talking about it earlier. As early, second trimester, early third trimester, talk about it early and often. I think the more we talk about it and dialogue about it, patients will understand what it means. We should use peer counselors. For some sites that are doing centering, it should be part of that conversation around prenatal care in terms of what postpartum looks like. Using our intrapartum support staff or messaging when patients are in the hospital, just delivered, what does that postpartum care in the hospital look like and how we can message that. Like I mentioned, using our postpartum nurses, that should be part of the discharge instructions and conversation. If we have discharge planners, whether that is nurse navigation or whatnot, then we can use them also to help schedule appointments during that in-hospital postpartum care. So before they leave the hospital, they have a visit in the first 3 weeks, if not sooner, depending on their medical situation, that they have that connection to postpartum care. I think we have to get a little savvy and start to use technology to help us, whether that's direct emails, apps that can help us and signify it's time for your postpartum visits, or even a chatbot. We have used that at my institution with great success. Believe it or not, greater than 50% of people engaging with a chatbot. And for those just quick texts on your phone, that's pretty high engagement. So we're happy to see that. Next slide, please. So this is just a pictorial of what that postpartum process looks like. And so, something maybe you can put up in the office, share with patients so they have an understanding of what postpartum process looks like. Like I mentioned, like it was recommended contact with all women within the first 3 weeks. If anyone has elevated blood pressures or blood pressure disorders, probably a blood pressure check within the first 3 to 10 days is necessary. And then any other high risk condition really should be seen within the first 1 to 3 weeks. And then you have your ongoing care from 3 weeks onward to 12, they would say. So you notice I said onwards to 12. I mean, the 6 week point that everyone is aware of, sure, that can happen, but it's not the definitive, it's not the end anymore. So I think that's important for us to understand and to really make this transition to wellness is to incorporate a good 12 weeks of follow up as needed. Again, it had to focus on what the patient needs. If she needs to come back after that traditional 6 week, then have her come back. And that's totally fine. Okay, so next slide. And so this is a postpartum checklist that is available for patients on the patient-facing website of ACOG.org. I think what this is great, it's important for our patients to have a postpartum plan, a plan in terms of who their providers are, not just their healthcare providers, but also who their community support is. This plan should be reviewed and updated with healthcare providers, with their community support network. Oftentimes, mothers are uncertain about when to contact for postpartum care or questions, and so having this laid out is important. And I think it's a great resource and something that you can give to patients early in pregnancy, not just at that last visit or even before they deliver, not just before they leave the hospital as well. Next slide. And so part of that postpartum care plan is the care team. And like I mentioned, not just the healthcare team, but also who is their support team? Who do they have at home? Is it girlfriends? Is it an aunt? Is it a grandmother? Is it their mother? Neighbors? Who is their care team so that the patient knows who they can reach out to in case they need something? I think part of the care plan should be what those postpartum visits look like, when they'll be, and what's going to be reviewed then. Looking about should also be discussed is the infant feeding plan, and what their resources are if they're having any problems with breastfeeding. Like I mentioned before, the reproductive life plan, very important. And again, we want to engage the patient in terms of what that looks like for her and her family, not us being prescriptive to say, you need to have this, you need to have that. I think we need to talk about any pregnancy complications or adverse outcomes. We've had if you have a patient that's had preeclampsia, eclampsia, any preterm labor, we need to talk about that and what that means. Talk about the mental health aspect of postpartum and how they're doing. Acknowledge, yep, this is a struggle, this is hard. What do you need? How can I help you? And again, the chronic health conditions is going to be important to talk about early and to continue as we talk throughout the entire postpartum time period and the transition into wellness care. All right, next slide. So I would be remiss if I just didn't put this one slide in to just make sure everyone is aware of the adverse outcomes associated with atherosclerotic cardiovascular disease. And so there's really good evidence to show preterm delivery, gestational diabetes, gestational hypertension, preeclampsia, eclampsia are associated with increased risk of cardiovascular disease later in life. So I think that is important for us to talk about this and talk about it often. I love the statement that pregnancy is a natural stress test for identifying at-risk women for cardiovascular disease. So I don't want us to be remiss to not mention this and to not incorporate this in the transition to postpartum care. Next slide. So here it is, the elephant in the room for some, the policy around postpartum care. So we know that paid parental leave is very important. It is essential to improve the health of women and children and to reduce disparities in our country. There is a lack of paid parental leave and policies around benefiting early life for the infants and for the mother postpartum. I think I'll be very honest, I think it's a huge injustice that we have here in the United States. And for those that are disadvantaged in our society, unfortunately, they bear the biggest burden. The two graphics on the right are pictorials of paid parental leave. The top picture again is paid leave for new mothers. So you can see that orange and light yellow are bad. Greens and darker the green, the better in terms of paid leaves for mothers. The pictorial beneath that is actually the paid leave for new fathers globally. And so, same, orange and yellows are not good, and greens and darker greens are better. So, you can see where we in the United States land in terms around paid parental leave. I think this is something that lots of people are talking about. I don't, I think there has been movements locally and on a state level, nothing on a national level yet. I say yet because I am hopeful that that will change. But I do think that there is work to be done. There are some local state legislators that have made legislation around paid parental leave. There are some organizations that for their employees have paid parental leave, but again, nothing that is substantial on a national level. Reimbursements for postpartum care, reimbursements for prenatal care needs to be reimagined and looked at. There's a big discussion about unbundling prenatal care so that healthcare providers can get reimbursed for the immense amount of work that many of us do. Also, now with postpartum care reimagined, and it's not just a single visit, but ongoing care, it is difficult. I mean, we have to look at the finances and making sure that we can provide the care that we need to. And if the finances aren't right, it just makes it a little bit harder. One area that we have had some success in is having 12 months of postpartum Medicaid for our new moms. So this has been made a permanent option for 49 states and the District of Columbia by the American Rescue Plan Act of 2021. Now, while this was made available, it was not mandatory or made for every state to adopt it. So currently, there are 30 states in the District of Columbia that have adopted the 12 months of postpartum Medicaid. I do know that in Arkansas, coverage is through 60 days, but the state legislator has not yet adopted the 12 months postpartum coverage in Arkansas. If that has changed, someone please tell me, but that was the latest that I saw. And so, well, work to be done, right? And so we're there, but I do think that if we have the policies behind us, it will help us to do what we need to do around the ongoing process of postpartum care. So we need to have this. We're still fighting ACOG, American College of Nurse Midwives. All of our colleagues in this are fighting with us, but there's definitely still work to be done. Next slide. So I'm going to transition and just talk about the postpartum discharge transition bundle. Just really high overview. Hopefully this will foster some good conversation and answer some questions. But I'm going to go to the next slide. And so, like all the AIM bundles, the 5 R's, readiness, and to start off with the postpartum discharge transition, we want to make sure to get ready for this. So you want to make sure you have referrals for our patients, referrals to any subspecialists, breastfeeding, lactation consultants, mental health providers. Let's get all your resources together. Then you want to make sure that you have very clear communication pathways, not just for the patient and her OB providers, but also OB providers and state or public health agencies, community-based organizations, and the affiliated OB provider for the patient. We want to make sure that we have those communication pathways very readily identified and easy for all those involved. Having a standardized discharge summary is going to be important. Something that clearly states how the baby is, what the APGARs were, something that the new parents can take to perhaps a pediatric appointment to give information, but also something that the new mom can take back to her own postpartum visits in case there was some unknown development during intrapartum, like if they developed eclampsia or some other a postpartum hemorrhage that we need to look at. And then we want to make sure that we have education on life-threatening complications, your early maternal warning signs, those are them. And then having trauma-informed protocols are very important. Get ready. The process intrapartum, the process of delivery can be very triggering for some, and we want to make sure that as a collective unit, we are ready. When I say we, not, all members of the healthcare team, from our nurses, our midwives, our learners, medical students, residents, and the attending faculty as well. So you want to make sure that everyone is ready. Next slide, please. The next R stands for recognition and prevention. So you want to, if the ideal situation is to have a system for scheduling follow-up before the patient leaves the hospital after delivery. So it would be great that our nursing colleagues are discharging a patient and either on the paperwork or just verbally say, and your postpartum visit is scheduled for this date. So you want to see if that is the ideal. Sometimes I know it's hard, especially with all the different systems. Patients may be coming from different places and so forth, but we want to try that. We want to try and see if we can make that feasible. You want to also screen for risk factors, like I mentioned, and provide the resources. And this is where the trauma-informed care can come in very carefully in terms of how we ask that. A lot of organizations are doing automatic screenings for social determinants of health. And how that's done is really a really good point for debate and discussion. Some will come and be very clear around, do you feel like you have enough food to take care of you and your family? Do you have secure shelter? Those are some ways, but we have to also recognize that even some of those questions, no matter how cautious we are being, could be really triggering for some of our patients. And so we have to, get to know our patients. Perhaps asking in a more open-ended manner might be more helpful for patients and might allow patients to be a little bit more free in terms of what they need. But that is, I'm happy to talk about that a little bit more because I think that could be a whole presentation in itself on screening for social determinants of health and getting our patients the resources they need. Again, I keep mentioning this because I think it's important, but offering the reproductive life planning discussions to share decision making around reproductive planning for the future. What does that look like? And it will look like something different for each of our patients, but it's just how we approach it and how we engage our patients around that discussion. Next slide, please. And so next is the response, the education upon discharge for the life-threatening postpartum complications. Like I mentioned, the early maternal warning signs. There are posters, there are handouts. It's just important that we go over this with our patients. We want to make sure that we have designed what that comprehensive postpartum visit looks like. And when I say design, can we have our electronic health record help us a little bit more in making sure that when we open the note type for a postpartum care, we're hitting the physical, the mental, the social, we're hitting all of that already within the chart. We want to make sure, again, I know if you have learners with you, if you people new to practice, that we are enforcing this reimagined, this new postpartum process. So just to make sure that all the visits are truly comprehensive and what they need to have. Having a postpartum checklist that we can give to our patients so that they don't forget anything when they come to the visit and to speak to their healthcare provider, that they have all of their topics covered and all their questions. So having that checklist, like the one that I mentioned that was available on the patient-facing website of ACOG.org, is a great option. Having the postpartum team and who are those folks, both in the healthcare arena and outside of the healthcare arena, right? So internally, is that a nurse navigator that's going to be part of the patient's team? Is it the physician, midwife, resident, nurse practitioner, and the nurse in the office, the discharge nurse on postpartum? Is it who makes up that team so we know who the patient can go to, we know who we can ask questions, because I think we all know that many times patients will tell different members of the team different things. And so we want to make sure that we're all communicating so we can all make sure we have the best information to help the patient. And I think we need to encourage our patients to have a postpartum team. Like I mentioned before, is that a neighbor? Is it an aunt, a cousin, work colleagues, family members, just to help them through this postpartum time, just so they know they have someone to go to and they're not alone. Next slide, please. The next R in the AIM bundle is for reporting and system learning. And so I think it's important as you guys come together on your PQC is to share success stories, share how you overcame some barriers and made things better. If there are areas for improvement and everyone is struggling with it, come together, brainstorm about it, talk about it. One thing that I love, and even at my own institution, we don't do this yet. I really want to, is to huddle before discharge on high-risk patients. So bring together the provider, bring together the nurse, the tech. We do some specialized rounding around discharged patients. We have a team that rounds on patients to be discharged. Maybe talk about some of the high-risk conditions then. Like I mentioned, again, if you have the right visit template, you can probably pull some really good data from there and really look at the data that you're seeing in your postpartum care. Monitor or develop and monitor some quality metrics for the postpartum. I think that'll be important. How many patients follow up in a timely fashion? How many patients inquire or have a discussion around their reproductive life? How many patients are following up or are transitioning from their OB health provider to their primary care provider, and see it so they can continue on with routine and well woman care. So those are all just different types of metrics that you might have. And I, employ everyone to look at some of this postpartum data metrics aggregated by race and ethnicity, so we can see if we are truly being equitable in the care that we are delivering. Next slide. So this last R is the respectful, equitable, and supportive care. So I think here, in addition to looking at some of our outcomes by race and ethnicity, but including the postpartum patient and their care team, their support system, as part of our multidisciplinary care team is very important and will help, I think, in some of our most vulnerable patient populations. Engage in transparent and empathetic communication with the patient and their support network. Not everyone starts off at the same place, and we need to oftentimes meet patients where they are. And I think as we keep that in mind, I think then we will have better outcomes and better engagement from our patients. Next slide, please. So, are we there yet in terms of optimizing postpartum care? So again, ongoing process, not a single visit. I do think we're really wrapping ourselves around this concept. I think we're doing a much better job, especially around some of our chronic medical conditions, particularly high blood pressure, any mental health disease. I think most people are bringing them in. I think we're getting a clearer, comprehensive postpartum visits. It's not just, oh, let me take a look at your decision. You're good. Okay, you're out. Okay, bye. I think we're doing a much better job. It takes a village to do this. The patient's postpartum team, the clinical specialists, the OB providers, peer support. It really, really does take a village to really make this happen. And maybe we can liken ourselves a little bit more about how some of our other cultures and regions globally are doing it in terms of taking care of our patients. The policy work. There is still a lot to be done. We know that. We're in the desire to do things around policy changes in postpartum care, it ebbs and flows. I think right now we're ebbing, we're not flowing really as where we'd like. We've had some strides, but we have a lot more to do. So I think there's opportunity there around the policy work. So still needs to have lots of conversation with your state legislators and a bigger conversation on a national level. Next slide. So I want to leave us, this is just a presentation. I'm looking forward to the discussion and questions, but the last few steps to reach the goal are often the hardest. So don't give up now. We're almost there. We are almost there on truly optimizing the postpartum process.